All right. Good evening, everyone. Welcome to Walls of Wellness. I am your host, Dr. Kathleen Walls, and I am excited to have this guest here with me today. Now, if this is your first time ever joining one of my shows, I tell everyone make sure you have a pen, a piece of paper, a tab open, some way, somehow to capture some notes because you're going to hear something tonight either for yourself or for someone else. And we want to make sure you capture it. Of course, you can always watch the replay and capture it there as well. But it is important that you at least know where you heard it, what point in the show you heard it. So I am super excited to have wellness and health advocate, a champion for wellness and health, Steffanie Goodman. How are you doing this evening, Steffanie?
Dr. Walls, I'm doing well. Thank you so much for having me.
Of course, of course. So you and I had a chance to meet through a mutual acquaintance who is a champion in her own right, Dr. Nia Bailey. And she does amazing work around breast cancer and just health and wellness and so forth. And she met you, she met me, and she was like, "Oh, you two need to know each other."
Yep. Dr. Nia is a connector of,
Mm-hmm.
she has a lot of superpowers and being a connector of people that need to meet each other and organizations that need to come together. She makes it happen.
Definitely, definitely. So, would you take a moment and just introduce yourself to the audience? What is it that you do? How did you even get to be doing this stuff?
Sure thing. So, where do I begin? I have always been very passionate about health and wellness, and I got a master's degree in public health. I'm living in New York City 25 years ago, and I moved across the country to California, to San Francisco, California from New York for my very first job out of graduate school, where I worked for the University of California, San Francisco.
Excuse me.
At a research center there that was studying, they study alternative and complementary medicine.
Mm-hmm.
It's integrative medicine.
Mm-hmm.
And I've worked I was there for 6 years. I then went to the private sector of healthcare and worked in managed care and then in the life science sector, and then pivoted to working in health policy and government agencies in conducting their program development and evaluating the success of their programs and research. And then pivoted again and was helping support operations for small health tech startups because I live in the Bay Area. So that's, I'm surrounded by health tech. So I did that for a bunch of years.
Mm-hmm.
And then in 2019, I met Dr. Laura Esserman, who is a breast surgeon and the director of the Breast Care Center at the University of California, San Francisco. I actually met her socially, and she told me about this really amazing landmark research study that she had pioneered. It's called the Wisdom Study. Women, and that stands for, because all great academicians and doctors like acronyms. Government agencies, and
we love acronyms.
Wisdom. It's a great name. You can't forget it. You want to know more, but it actually does stand for something. It stands for Women Informed to Screen Depending on Measures of Risk. Kind of a mouthful, but I'm telling you how the story unfolded and how I came to be where I am right now. So I looked to see what this study was all about. It's a study of personalized medicine from a high level. It's personalizing the way women can be screened for breast cancer. I thought, this is amazing. I am a huge proponent of personalized medicine and understanding that this is the forefront of healthcare.
Yeah.
And, in all my experience working to try to develop reimbursement strategies for life science companies and health tech companies and go-to-market strategies, I knew that a really important part of the process is developing evidence through research to prove out to payers, health insurers, that what you're doing makes sense and that there's proof that what you're creating, whether it's a medical technology, a device, an intervention, a pharmaceutical, that it's as safe and effective at whatever the standard of care is, and that payers like to see that there's cost effectiveness, or that it's not going to be a burden to the medical system. So I thought, oh, this wisdom study, I want to help. I want to be a part of this study in any way that I can, because I think to prove out that personalized medicine is effective, I want to be a part of that.
Yeah.
So I joined the wisdom study first as a participant, and then I ended up starting to work for the study.
Look at that. Look at that. Tell me this. You mentioned the term earlier, just so that people understand. When you first moved out to California, you said you were part of like integrative medicine and so forth. What exactly does that mean?
Yeah, that's a good question, because that's kind of it can be a catch-all. The organization that I was working for then, it's the name of the org is the Osher Center for Integrative Medicine. And what the Osher Center does is they provide patient care. They're a clinic, and they're also a research institute. And they provide care that is holistic, in that they provide biomedical care. So it's Western biomedicine, like you see an MD, but they also kind of round out the patient experience by offering access to clinicians who are trained in more than one field of medicine. So the practitioners there, they call themselves integrative because they had MD training, allopathic Western biomedicine, and they may have had additional training in nutrition science. They may have had additional training in like Ayurvedic medicine, Indian medical system, traditional Chinese medicine. Some of the practitioners there were MDs with acupuncture, licensed acupuncture. So they had doctors of osteopathy, naturopathic doctors. So in that context, integrative medicine meant different interdisciplinary fields to support a holistic perspective.
Definitely. Yeah. Well, that's about as integrative as one can get. That's
But the one thing that I didn't include there that is very integrative, coming from my public health perspective, also understanding the environmental aspect of where someone lives and comes. And their community, the impact of their community and their community relationships. So if we want to get fully integrative, consider those.
Thank you for bringing that up. It's so true and so important. There's a community that I'm working with now, and we're looking at holistically what's going on environmentally, that our health factors, right? Risk factors, rather, for people's health. The neighborhoods and all of those different pieces obviously all play within our emotional health, our mental health, as well as our physical health and social health.
Yep, definitely. You can't leave it out, because neighborhoods and environment impact our health. And that's something that we'll actually talk about in the wisdom study.
So we fast forward to current, and you, as you said, you started out as a participant, and now you are actually working for and with the study.
Yes.
What was it about the study that you said, I need to be more than just a participant?
That's when I learned about this research study. What really blew me away, it was that it's not a typical research study. Oftentimes in research studies, participants might be giving data, giving blood, giving saliva, giving information about themselves. And sometimes in clinical trials, you might take a pill or medicine to test out if it works. But in the wisdom study, you're given the benefits of the program. To me, it seemed like this is a highly educational program that anyone who decides to participate is going to learn about breast health. I loved the fact that what Wisdom is doing is testing out a personalized approach to breast screening based on an individual person's risk for breast cancer. you get the opportunity to learn about your own individual risk factors for breast cancer. And then you get the opportunity to do something about your risk factors. So it also is, this study includes prevention and education around prevention. And I loved the fact that it's a population-based study, meaning that we're looking at the impact of this intervention on a population level. We're enrolling 100,000 women into the study from across the country. So it's really going to move the needle and impact, make an impact on the world right now from impacting the lives of people who participated in the here and now. But I loved the fact that if the study could succeed in enrolling enough women across the country, and they might be able to improve clinical guidelines around breast cancer screening. And I thought, like, that's huge. I want to be a part of that. I want to be a part of something that could make a real change in the system and not take 20 years to do it, and also to hopefully do no harm. So wow, if I can help the study by bringing my experience and expertise in like marketing and communications and the real practical skills that I would bring to my work, but do something that is meaningful to me and really up and that I believe in, that to me is like the holy grail of a career. So I asked Dr. Esserman, how can I get involved? And she said, well, we really need help recruiting women. Can you help? And I was like, yeah, absolutely. That's why I joined the study. That's how it all, that was 2019.
And I was about to ask, I was going to say, and that was 20 what again? Yeah, so 2019. So here we are 6 years, almost going on 7 years later.
That's incredible.
Yes.
And what's also incredible about the trajectory is that I came on board with a study working part-time for them, helping to develop marketing and communication strategies. That was right before COVID.
Yeah.
And then COVID hit, the world went upside down. And interestingly, that really actually kind of benefited our ability to enroll and recruit women.
Oh, I'm sure.
Almost entirely online.
Yeah.
Suddenly, we weren't trying to reach out to people by flyering and canvassing.
Yeah.
We're doing all digital outreach and trying to recruit women from the comfort of their own home. The study's done all from your computer. So now we have captive audiences who are ready to contribute to medical science and women's health.
Look at that. Look at that. It's so amazing. There's a couple things that jumped out at me, was the fact that you said to be able to participate in something that is making a change now, right? That you can see. And so many times when it comes to studies, people are hesitant to participate for a lot of reasons. Historically, there may have been lack of informed consent. Culturally, we know, when it comes to Black people, there has been some wrongs when it comes to research. So there's hesitancy there. The ability to, what is the word that I want? Generalize the findings to other populations has been a challenge, where it's like, well, that might have been true for them, but not for me. And it sounds like you all have taken those things into consideration with this particular study.
Yeah, absolutely. I mean, the lessons learned from mistakes of the past in human subjects research is not lost on our study. And we have a team that is diverse and is representative of the different communities across the United States. And it actually is one of our missions is to reduce breast cancer disparities experienced by women of color who are disproportionately impacted by breast cancer. We know that women of color get the more aggressive, harder to treat breast cancers. We know that they're diagnosed at later stages, and we know that they have higher mortality rates and some comorbidities. And so our study has part of my ability to be working for the study full time is that in 2020 we've received we're grant funded by federal grants. The National Institute of Health, the National Cancer Institute, the Patient-Centered Outcomes Research Institute. We also have philanthropic grants, and other donors have awarded us money. But we're upwards of the Department of Defense. Also, we recently were granted.
Oh, wow.
But we have, I think, over $40 million worth of grants that we've received since 2015. But in 2020, one of the awards that we received was specifically to increase diversity in our study to achieve the improvement around breast cancer disparities, and try to uncover some of the genetic associations that can be causing disparities, and also to build relationships with community leaders and have community leaders and diverse people represented in our study team. So when you talk about like mistrust that's come from abuses in health and human subjects research over the years, we've kind of tried to build from the ground up to prevent any types of abuses of power, anything like that from ever happening.
That's wonderful.
So health equity is one of our pillars that we're working toward.
And I think that's important. Obviously, you know this, it's important that people know that, and that it has been taken into consideration, and that, you're working very hard to ensure that equity is there, making sure, removing those barriers, because people's perceptions and lack of trust and so forth are huge obstacles in conducting research. And we need the research in order to make the improvement. So it's like we got to trust each other and build this really kind of quick, fast relationship, so that not only can we help people in the now, but we can also help people in the future.
Yeah, absolutely. And I've heard people say in the community, like, we can't be represented if we don't participate. And
that's right.
And that's what part of it is about, engaging in research, so that that the information can be learned to then, come full circle and improve the way that we practice medicine, and the treatments that are created that can be targeted specifically to different communities.
Yeah.
It's the only way to learn and do better.
Yeah.
To participate.
Let's tell them about the study and what they can do. I've been dropping the link in the chat room, so they can click on it. It'll take them to the wisdomstudy.org, and I'll continue to populate it. But go on and tell them about it.
Oh, cool. Thank you. Yeah, I'm just seeing. So I'm kind of new to this platform that we're speaking on. So I didn't realize that there was a comment in the chat section. Thank you so much. So this is the fun part. The Wisdom Study, Women Informed to Screen Depending on Measures of Risk. Blah. Right? It's a study that's conducted almost entirely online. Any person who identifies as female living in the United States can join the study if you're between the ages of 30 and 74, and if you've never had a breast cancer diagnosis. So we're looking for cancer-free volunteers to join the study between the ages of 30 and 74. Doesn't matter where you live, doesn't matter if you have health insurance. The way the study works is we are looking at understanding and proving out our hypotheses that a personalized approach to screening, breast screening like mammograms, based on your individual risk factors, what puts you at risk for breast cancer. So giving you your own screening plan will be as safe and effective, if not more, than the current standard of care, which is annual mammograms based on your age. So generally, the standard of care right now is to get annual mammograms once a year, starting at the age of 40. It's an age-based strategy, so it really doesn't take into account any risk factors. Now, there are 7 different clinical guidelines in the United States right now that indicate when a woman should get screened, how often she should get screened, and there's some controversy around what the best approach is. Depending on who you go to see as a medical provider, depending on your doctor, depending on your health insurance, your screening recommendation may be different than mine, simply because of whatever guideline my doctor might be following, the American Medical Association or the American Radiological Association or the U.S. Preventive Services Task Force recommendations, 7 different guidelines in the U.S. So there's controversy around which is the best approach. So we're trying to create clarification by capturing current evidence through a huge data set. We're trying to enroll. We're almost at 100,000 women across the country to show that personalized screening is better. So what we do is, if you're interested in enrolling, you go to our website, wisdomstudy.org, and you would fill out a questionnaire. It takes about 25 minutes online. It's a breast cancer risk assessment. We use a validated model called the Breast Cancer Surveillance Consortium risk model. There's a lot of different breast cancer risk calculators out there, but we use one that's evidence-based and tested in large populations. And you get a choice of which group you want to enroll in our study. Okay. If you want to get annual mammograms because you've always had annual mammograms and you're like, I don't want that to change, I believe in this approach, you can enroll in what's called our annual group. And if you enroll in that group, you're going to fill out a questionnaire once a year about your breast cancer risk. And you're going to continue to get annual mammograms as you always have, wherever you usually get them. And behind the scenes, we'll collect your mammogram reports. If you can share them with us, you can upload them or email us your mammogram reports. So we're capturing some data around your mammograms. That's we're capturing your breast density information that's within a mammogram report, and we're capturing a BI-RAD score. We're looking at how dense your breast tissue is, and then if you want to be in our personalized arm, which is actually our test arm, you would join the personalized group of the study. And what you would do in that group is you would fill out that same breast cancer health questionnaire online once a year. But we will send you a genetic test kit, a saliva-based genetic test kit in the mail to your home. That's a picture of it on the screen that you're showing on the right-hand side. It's Color Health provides our genetic testing. And we are looking at 29 hereditary cancer genes. We're looking to see if you have any mutations or variants on 29 different genes associated with a range of different cancers. And we're also looking at hundreds of microvariants in the DNA. That these SNPs is the acronym for those single nucleotide polymorphisms. That individually, these little microvariants, they don't tell a story, but collectively, when you're looking at hundreds and hundreds of these SNPs, they can actually indicate if they put you at risk for developing a disease or if they can actually be protective against developing a disease. So the researchers and scientists are finding now that the SNPs actually can increase or decrease your risk of developing a disease, even if you don't have a mutation on one of the primary genes. So what we do is we factor in your polygenic risk score. We factor in whether or not you have any mutations on any of your genes associated with cancer. And then we factor in all of that information that you gave us online in the questionnaire. That's your comprehensive breast cancer risk assessment. And then we give you your results of your genetic test, and we develop a personalized screening plan just for you that will tell you when you should get a mammogram, how often you should get them. If you're at an elevated risk level, we may recommend that you get an MRI and alternate it with a mammogram every 6 months.
Mm-hmm.
And for women that are in a certain risk level, we may recommend that they get or that they consider taking risk-reducing medications to reduce their risk. And for women in the highest risk category, we also match them with one of our breast health specialists. These are MDs that are on our study team.
Wow.
That will do a one-on-one consult with you and take you through like an hour-long presentation showing you your risk factors, showing you what factors could be reduced or improved upon with different like medication therapy. Or they may say, we see that you've got a mutation on a significant gene. For example, if you had like BRCA1 or BRCA2,
yes,
you may want to go get an MRI right away, and our team will help you find the care that you need in your region to help you find a local healthcare provider.
Gotcha.
To be seen right away.
Wow.
Yeah.
Wow.
So it's a very high touch study, despite that we have like almost 100,000 people enrolled.
It's amazing.
I really believe in this trial.
It's amazing. So I know when you and I had spoken off camera, tell me again the starting year of this study.
Yeah, the study started in 2016.
Right. And so with the goal of reaching 100,000?
Yes, we had the goal of reaching 100,000. And during the course of the study, we started out with what we called Wisdom 1.0. That went from 2016 to 2023.
Okay.
That version of the study had a genetic test that looked at 9 genes associated with breast cancer risk, and was using the Breast Cancer Surveillance Consortium model, like version 1 or 2.
Okay.
But science changes in real time, and we learn as we go. And as the study learns, and as scientists make breakthroughs around genetic information and how it impacts for breast cancer, we update our risk models in real time. So we are now on version 2, Wisdom 2.0 of the study.
Right.
We launched that in 2023 or early 2024. And 2.0 expanded our genetic tests. So now we're looking at the 29 different genes associated with hereditary cancers.
Okay.
We have a more robust risk model, which helps us be able to more accurately predict someone's risk of developing a cancer and give more precise recommendations for a specific risk level.
Okay.
And we previously enrolled women just between the ages of 40 and 74, and now we enroll women as young as age 30.
Wow.
Part of that reason is because we know that younger breast cancer is on the rise.
Yes.
And we know that women under the age of 40, though the incidence of developing cancers is still low in a young population, when younger women develop breast cancer, it's usually more aggressive.
Yeah.
So we want to catch those. We want to find out and say, like, learn your risk before it becomes a problem.
Yeah. You know what, Steffanie, question for you. Do you all go out to like middle schools and high schools and things like that and talk about these things?
It's a really good question. We have not done it on as large a scale as I think we would all like.
Yes.
We've tried to break into school systems by like finding teachers unions and finding schools to like let us come and speak.
Yeah.
And I honestly haven't had tons of success. I think part of it is because people are so busy.
Yeah.
And I think that teachers have a lot on their plate.
Yes.
One of the ways that I was reaching school systems was just through friends who are teachers. They were letting me do like e-blasts to them. I presented to a group of teachers once, like a lunch and learn. Really one off. Oh, we also have had some high school interns take on study and want to educate their peers so that they can educate their parents about it.
Yes.
Yeah, that's something I would love to do.
I'm thinking about it, and as our listening audience is thinking about it as well. And Steffanie, if you can put your contact information in the chat room, an email or phone number, because I'm just thinking so many times, like in health class, right? Many times students are taught about these things or their lives. I remember my classmates or someone who might not have been in my class, maybe a year older, when a mother passed away from cancer. Like it impacted us all, but nobody talked about it. And just the importance of more awareness and being an advocate for a study for an older sibling or relative or so forth, encouraging them to care for themselves in such a way. And I also remember speaking with an eighth grade class. It started out with just talking about social skills, and it went into me doing a genogram with them about the health history
Uh-huh.
within their family. And they started talking about, well, I know I'm going to have diabetes and I know I'm going to have, and these are 13 and 14-year-old children. And they're saying, I know I'm going to have this because my mother has this, because my father has this, because my grandfather. And it was a great opportunity for me to talk about adopting healthy practices and ways in which they can monitor their body and making sure that they're visiting their primary care physician and what that even means and what that should look like. But had I not gone in to talk about something completely different, we would have never even have gotten there. And so many times when I think about students who graduate from the eighth grade, I remember one in particular, and I was interviewing them, kind of like exit interviews.
Mhm.
And I said, is there any message that you would like to give to your teachers? And this one child said, you all taught me how to be a great student, but you did not teach me how to live my life.
Whoa.
And the teachers were aghast because I was doing a fishbowl. So I had like a bunch of students and we were talking, and all the teachers were sitting around. Yeah,
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 that that
that
hurts.
hits,
Yeah.
right?
Hmm.
And the teachers had to sit with it because they were not allowed to chime in.
Oh my gosh. Oh my gosh.
Yeah,
That would have been really, really hard to hear. And I
mhm.
imagine that they may have wanted to change their
Their
approach.
methodology, without question,
Yeah.
without question. And it did. And some teachers that following year, boy, was there a change in the way that they were teaching and talking, like about math and variables and explaining life variables. Like in algebra we learn it at x and y. In real life we learn it as situations that happen in life. Oh yeah, there was a major shift for some of the teachers after that comment. Yeah. And so I'm just thinking, and especially now with the way in which young people use TikTok as a search engine,
Hmm.
right? They're exposed to so much more information and they want to know what to do and how to live life effectively, that I think maybe starting to tap them, be it career days and things like that, that may be a way to start
That
getting
is
information to them.
that's such a great idea to integrate it into bring the information to the communities, to people, to young
Yeah,
people, to hopefully tell their siblings and cousins and aunties and mothers and
that's
friends and
right.
sisters.
Yes. And
Um,
fathers and brothers, right? Because we know the number of men who are diagnosed with breast cancer, and many times they get overlooked. I know in this particular study, we're focusing on people who identify as women, but
mhm.
that is a population that often gets overlooked as well.
Yeah, absolutely. I know it's a low incidence. We weren't able to integrate that into the study,
Mm-hmm.
offer it to men, but we know that men absolutely do get breast cancer.
Yeah.
They are
Yeah.
unfortunately overlooked.
I'm
Yeah.
going to bring this comment up. This is from Edna Warren of the Health Zone. She says, I'm a survivor of thyroid cancer, breast cancer. She had a lumpectomy and uterine cancer. And she asked, was she a candidate for the study? So she missed the first part. So go ahead and tell people who are just joining us again.
Yeah, hi there. And I tried to join the chat, and I must have some type of firewall that's preventing
Oh, okay.
hard from letting me do it. I don't know what I'm doing wrong, but
Okay.
I've been trying to connect.
Check, you know what, Stephanie, there's a side thing that says comments, and then one says private chat. Check and see if, make sure you're clicked on the one that says comments as opposed to private chat.
Yeah, so I put my email address in the private chat for you so that you can copy it and paste
Got
it. The comments, but I'm not able to join the chat.
Oh, okay. Well, you just keep doing it that way. And if you put anything in the private chat, I'll be on the lookout. So I just put her email address in the chat if you'd like to contact her. But go ahead and talk about the requirements, what's being accepted into the study at this time.
Yeah, thank you. And thanks for the question. So unfortunately, we don't enroll women who've already had a breast cancer diagnosis into the study. So we're looking for women between the ages of 30 and 74 who've never had breast cancer or DCIS, ductal carcinoma in situ. Okay. That's in part because we're looking, our endpoints in the study include stage 2B breast cancer. So we're looking to determine if this personalized approach to screening is better at earlier detection of breast cancers. So it can be a little confounding if we enrolled people who'd already had a breast cancer diagnosis in case they may have a reoccurrence. So that's why we're looking for people who've never had breast cancer.
And as far as participants, must they all be from the United States? And does it, okay, go ahead.
So as long as you live in the United States, you can participate in the study if you live in the United States, but you could be from anywhere in the world, really.
Fantastic.
Yeah. And we follow women. I didn't get to talk about the length of time that you're in the study. So if you were to enroll in the study, we aim to follow people at least 5 years, and we hope that people will fill out the annual questionnaire online each year. The reason why is because the questionnaire asks about your risk factors, and risk for a disease changes over time. It's not static. It's not like a one-time thing. You have this risk. A risk factor for breast cancer is actually your age. So, it's because majority of breast cancers are like postmenopausal breast cancers are hormonally related. So the older you get, as your age changes, it may put you at a greater risk category. And also, let's say you're a younger enrollee. Let's say you're 30 years old and you don't think you have any risk factors. You're in the study for a year, 2 years go by, and then unfortunately, a first-degree family member develops a cancer. We need to know that because that actually could change your risk for breast cancer.
Yeah.
The first-degree or second-degree relative, and they develop an aggressive cancer associated with a breast cancer, or some or related site, that could definitely change your risk. So we want to understand how people's risk factors are changing over time so that we can update their screening plan and say, okay, your risk levels now changed, that we have this new information from you. Now you may need to get or maybe your risk has reduced because you've lost 20 pounds. We know that that weight and obesity is also a risk factor for breast cancer. Exercise is so preventive. If you start an exercise, you're exercising 4 times a week, doing aerobic activity 4 times a week, or doing fast walking 5 times a week, you could have just actually reduced your risk.
Look at that. Look at that. All right.
True.
We have a question here from Medical Tourism, aka Dr. Ramental, says, who is funding this study, and is there any collaboration with the American Cancer Society?
Thank you so much for that question. That's fantastic. Yeah, we have a good relationship with the ACS. They are not funders of ours, but they're definitely partners of ours. We have funding. We have funding from a lot of sources. So I'm going to try to find my slide on all of the funding sources. But the NCI, National Cancer Institute, is one of our biggest funders. They're part of the NIH. And we also have PCORI funding, Patient-Centered Outcome Research Institute funding. We have about $6 million from the DoD, the Department of Defense. And then we have a series of different philanthropic grants. We have funding from the Breast Cancer Research Foundation. I I'll look for my slide. I'm still looking to get the
That's
full.
all right. I see here too. We also have Robert Wood Johnson Foundation.
Oh, we found it. Okay. Yes.
Yeah.
Yeah.
So we have a lot of different ones. I'm going to go ahead and pop that in
Awesome.
here. Let me see if I got everybody. So the Wisdom Study has been funded by the Patient-Centered Outcomes Research Institute, the National Cancer Institute, as she mentioned, the Breast Cancer Research Foundation, the Robert Wood Johnson Foundation, the Safeway Foundation, the V Foundation, Mount Zion Health Fund, and private donations from people like you.
Yes, thank you. I didn't mention that we have recruitment sites also across the country.
Oh.
Despite that the study is conducted almost entirely online, I should mention that we have partnerships with organizations across the country and recruitment sites. So we have partnerships at University of California, Irvine, University of California, San Diego, University of California, Davis, UCLA, University of Alabama at Birmingham, University of Chicago School of Medicine, Topline MD Alliance in Florida, Sanford Health in the Midwest, Louisiana State University, DHR is in Texas. So, and then we also have partnerships with like Blue Cross Blue Shield, Optum, and several other like employer groups.
Wow.
Yeah.
So there's ample opportunity for people to participate.
Yeah, and those recruitment sites, what they do is they serve as hubs where if you enroll in the study and you live, in some other geography, whatever hub is closest to you, that's where your clinical research coordinator will be located. And that's the clinical research coordinators are almost like the nurse practitioners in the clinician office. They're the people that are going to have the most contact with participants. If you have questions and need help getting study or need help with your signing a consent form or don't know where to send your mammogram report, things like that. The site that is local, closest to you in zip code, kind of help manage you through the study.
Now, you talked about the longitudinal nature of the study.
Yes.
What happens when somebody turns 75?
Oh, you'll stay in the study. You just can't enroll in the study beyond the age of 74. But, we've got people in the study who are 82 years old now, and they're still in the study. We'll continue to provide screening recommendations. And nothing happens to you if you turn an age that's beyond 74.
Okay. So that's good to know.
We try to follow people for at least 5 years, and you have the opportunity and the option to stay in the study as long as we have funding.
And as far as findings are concerned, are they posted on the site?
We're actually just starting our initial findings for Wisdom the 1.0.
Yes.
We have a big analysis happening starting this summer. So it's a really big time for us where we are starting the process. We have I'm glad you asked that question, because some of our earliest findings that we have not published yet, I think we have an abstract that we presented an abstract on this, is very interesting, significant finding. Through our earliest analyses of the genetic information, we found that I think it was out of the population of people who we ran the analyses on, I think it was like 70,000 people. 1.3% of the people who had completed their genetic test kit, 1.3% had a genetic mutation, which is great. That's a small percentage. That's great to hear that. But what was most surprising about this finding is that the majority of that 1.3%, I think it was 67% of the mutation carriers did not report a first-degree family member having cancer.
Really?
Yes. So what that tells, so we just take that in for a second. So the majority of people in our study who did have a genetic mutation didn't have a family member, didn't have a first-degree family member with cancer.
So what does that mean?
That means that there is more than just a family history is going to
Yes.
put you at risk for cancer.
Yeah.
So that means that there are other reasons why people will develop a genetic mutation risk for cancer.
Yeah.
And I think what makes that really important in a practical setting, like when we apply that information, what does that translate to? That translates to your primary care doctor or your OB/GYN. They're not going to offer you or suggest to you to get a genetic test to look at breast cancer risk unless you have a mom, a sister, daughter breast cancer. So there may be lots of people falling through the cracks.
Yeah.
Why would they offer you a genetic test to get it to look to see breast cancer?
Right.
Didn't, because that was the old way of thinking.
That's right.
That's what we used to know.
Yes. Yes.
So family history absolutely is a risk factor, but now we know there are many more risk factors.
Yeah. Thank you so much. That's so important for people to recognize. And I actually had a session today with a client and they were saying like, I don't know why I have this. And I said, well, is there a family history of what they were dealing with? And they were like, yeah, it was my mom and my dad. I said, well, you just answered your own question. Yeah. I said, it's not guaranteed that you'll have it, but it puts you you have a predisposition for it. You have a higher likelihood of a probability of it. So now you're telling me not only did your parents have it, and then it was like, oh, and my grandparents did too. Well, all right, now you got to make sure you're doing things to safeguard yourself from it exacerbating, right? And so as you're talking about the exercise and be it, optimal sleep and all the other things that your primary care person and your integrative team tells you need to make sure you're incorporating for your overall health and wellness.
Yeah. So family history will certainly, your family's history of a disease, whether it's physical health or mental health, can certainly put you at risk. And there are other risk factors, like we were discussing at the beginning of the call, the environment. I mean, there's a lot going on in the water.
Ooh, baby.
Soil.
Yes. Yes. All of that, and trash and incinerators and yes.
It's hard out there.
Yes, it is. And here in Philadelphia, right outside of Philadelphia is Chester, Pennsylvania, where I forget how many tons of trash are brought from all around the country, including, I believe it is Hawaii, and it is imported in here and then burned. There's a documentary called Trash and Burn by Bilal Motley, which it'll just blow your mind the way that this community is dealing with these environmental health challenges due to this incineration. It's mind-boggling. It's mind-boggling.
It's tragic. It's hard to exist in the world that we do live in, and this is what we've got.
Yeah.
But hopefully something like the wisdom study can at least empower you to understand the factors that you're facing and give you tools to hopefully help you improve your health or manage your health. We actually are integrating environmental risk factors into our survey now. This is a brand new sub-study funded by the Department of Defense. One of our scientists, Dr. Kim Vidal, was awarded this grant, and she's starting to disseminate residential history surveys and occupational exposure surveys to learn from our participants if they had any type of exposures to environmental toxins in their job history or residential history, which as of yet has never been included in these breast cancer risk calculations.
Oh, wow. Really?
Yeah. So this is big stuff happening.
You better believe it. That's amazing. My goodness. I'm just thinking, there's so many benefits to participating in this study. Awareness for self, but also awareness for loved ones, and as I mentioned earlier, for generations to come.
Mhm.
And so when I was thinking about what findings have you found so far, I was curious, and you may not know this yet. Do you have any families that have participated, like mother daughters, grandmother daughter? Are there any generational participants?
That's an awesome question. I know anecdotally that we do, because every now and again I will get well, I look, because I'm a marketing person, I look at incoming enrollment data, and people tell us how they heard about the study. So I see a lot of, I heard from my sister,
Okay.
I heard from my mom, or I heard from my daughter.
Yes.
And we also will get emails every now and again with people thanking us or saying like, oh, I
Mhm.
got it from my family member. We haven't looked at that in the data yet. And I'm not
Okay.
sure if that'll be in the analyses, but it would be very interesting.
Mhm.
Speaking of which, I hope I can just add this in for a moment.
Please. Yeah.
Speaking about the family history thing, this is just coming to mind because one of our participants, she's a woman, lives in California. She's a doctor, actually, primary care provider or women's health provider.
Mhm.
She learned about wisdom through her work at the Optum provider network. She works for Optum, and she learned about wisdom and thought, oh, this is very interesting. I would like to participate in this, because in the past few years, her mother and her sisters developed breast cancer. And she's like, oh, I really want to see what's going on and why this is happening. Interesting to note that her mom and sisters lived in different parts of the country. So there wasn't necessarily we don't know if there was like an environmental
Component. Yeah.
and I think her mom or her sisters did a genetic test, and there were no mutations on the primary markers associated with breast cancer.
Okay.
But we do an advanced genetic test that's looking at all those microvariants I told you.
Yes.
Most typically, if you were offered a test by your primary care provider, you would probably be tested just for the traditional, like 9 breast cancer genes.
Mhm.
But with wisdom, she got tested for the 29 hereditary cancer genes and all those hundreds of SNPs.
Yes.
She had never heard of SNPs before. She didn't know what single nucleotide polymorphisms were. It's like, well, I don't have my.
How you not know that? You didn't learn that? Look, come on.
I'm starting to be in the news. Now that we're talking about this,
Yes.
you're seeing it when you're reading like the New York Times.
That's right.
Or whatever. You might start catching it now that we're talking about it. But her PRS, her polygenic risk score, was elevated because of these SNPs, and it put her at risk for breast cancer.
Wow.
No, she never would have known. And so now they're thinking that perhaps that was the hereditary piece.
Look at that. Wow.
So I just raised that
Yeah.
because it is top of mind for me. I just spoke to this woman and wrote a blog article about her for our study.
That's amazing.
Mm-hmm.
That's amazing. So now, believe it or not, we're rolling up on the top of the hour that fast.
I talk a lot.
That's the purpose of the show, to get you to share all of this.
What to say?
So the link to the wisdom study is in the chat. Please be sure not only to take a look at it yourself to see if you qualify, but also be sure to share it with others, loved ones in this day of social media, with followers, with fans. Just post it, because you all are trying to reach 100,000. Do you know what number you're at currently?
We have, I think, let me look at our ticker. I think we have like 95,000 right now. Mm-hmm. We're not going to stop at 100. That was our 100 is our goal, but
right,
always going to work past that goal, because the more people we can enroll and share this information with, the better.
You better believe it. So please make sure you are sharing it out with people. For those of us who do these live shows, this is something that you can link in your write-up, so that people can go and take a look and see if they qualify for it. The more people, the better. I think about my father. My father started out in cancer research in the 60s.
Oh, I didn't know that.
Yeah. And so he started out as that before he went to veterinary school. And so then, years later, my father made his transition from cancer. And so it's just like, how is it that so much information has yet to be learned about this? And he participated in a trial medication that worked well for him for a couple of years. It worked well until it didn't. And his doctor, who was wonderful, said it's not usually the medication that stops working, it's the organs and other things that stop working. And so it was like, it is what it is, right? It gave us this extra time with him. So very thankful for it. But we just, we smile, we laugh, we love, and we say he was committed to the research, and he was committed to the research, and he did his part in the process. And this is a way in which we can do our part by just participating in the study and helping to provide the data so that those who are doing the medical portion can do their part.
Yeah, absolutely. Thank you so much for giving me this opportunity to share the information with your audience. And
yeah, you're welcome.
Share the message. And I'm always available for questions, and we love to do presentations to groups of all sizes to help spread the word.
Yes, thank you so much.
Calls.
Oh, yes, yes. All right, y'all. So look, you know the deal. Make sure that you are liking and subscribing to the channel if you haven't done so already. Please make sure to share the replay. Make sure to share the link to the wisdom study. Steffanie has posted, I posted her email in the chat. If you have any questions, you can always reach out to her. As she talked about, she's open to have more conversations with people, be on more shows. Dr. Ramantal, I know you have a fantastic show, that this may be a good person for you to bring on your show as well and reach your audience. And we have other people who, they know I poke them really hard to live on their life on purpose and with purpose, Steffanie. So they're listening and they're going, she's talking to me. Yeah, I'm talking to them. So that they're it's my gentle push and guidance. So, but the more we can work together, the healthier we can be together as a community. So until we meet again, as always, God bless and continue to live your greatest life. And I'll see y'all soon. Good night, everyone. Good night, Steffanie. Be well. All right. You're welcome. Thank you.